one of the backbenchers, so I understand that feeling. You don't want to come to us. So I'm going to talk about something different from what we do in everyday practice. I see some family neurologists who can help me as we discuss about this. So, very common question is, what is the neurointerventionist talking about headaches? Because typically when you associate neurointervention, stroke is okay. We have been making a lot of noise for last decade about stroke and aneurysm. But why we are talking about headaches? Because headaches can be of many types: tension type, cluster type, migraine, due to vascular malformations, could be anything. And I don't need to tell you all these, you are very experienced physicians, that there are red flags when you need to investigate with a CT scan or MRI, and when you rely on your clinical acumen that, okay, no, this looks like more of a tension type headache or migraine. And sometimes when we scan, we do find all these bizarre findings of a tumor, of a bleed. But the most common cause, which is especially in the elderly, is the subdural collection or chronic STH. And traditionally, if you find a subdural collection, as physicians, when we do in our practice, what will you do? If you find a patient who is having a headache and a subdural collection, you send to a neurosurgeon, right? To drain it out. We always believe that there is a bridging vein which has ruptured, and now the only option is to drain it out. And Sadhguru made it famous last year when he had underwent 1 then 2 surgeries, open craniotomy to take the subdural out. But what is new is emergence of middle meningeal artery embolization. So this is a new concept which has come, that the subdural collection, the chronic subdural which is happening, is not due to rupture of bridging vein. It's the artery which is leaking into the subdural space, and if you block that artery, you can actually control that bleeding, and eventually it will be absorbed, and many a times you don't need to drain them out. And some celebrities around the world, they have undergone this MMA embolization very successfully. And from there on, now we have also started treating chronic headaches and resistant migraines by the middle meningeal artery embolization. So it's the concept where you feel that the meninges gets irritated, they are having the inflammatory response, which is responsible for these chronic migraine headaches. So this is not the first line treatment for migraine, don't get me wrong. So you try pharmacotherapy, you try all the methods, but then if you are going to 3-4 pharmacotherapy, the headaches are still not controlled, then middle meningeal artery embolization is becoming the treatment of choice for these patients. So coming back to the chronic subdural, we all know it's a very common cause. The numbers, the incidence is far more than what we do in the entire neurointervention spectrum. And for last 2 to 3 years, as we have started doing more of these subdural, our major practice suddenly has become the embolization of subdural rather than the stroke and aneurysm. So this is the pathophysiology of DBC, as we call dural blood cell layer, that instead of a bridging vein, it's the inflammatory response which is mounting on these dural blood cells. That inflammation can be triggered by anything. That can be triggered by a minor trauma, violent coughing, sneezing, just shaking of head. And once it starts, there is a self-perpetuating cycle, that there is an inflammation which leads to more new angiogenesis, and as we know, the new angiogenesis, the arteries are more leaky, the blood-brain barrier is not tightly sealed, they start to lose more blood, which leads to more inflammation, and then the cycle goes on. So typically, as I said, before 2023, the treatment was to drain it out, and the challenges were, most of these patients are elderly. They are on blood thinners, they have cardiac risk factors, comorbidities, to do under general anesthesia or even away.
So that is why they will educate.
And the chances of recurrence is also high. you are draining it out, but you are not securing the source of it unless you do a whole craniotomy, exposure, using, and the mortality and morbidity of these procedures is also high because of the population which we are dealing with. And that's where the MMA embolization becomes complementary, I'll say. In not all cases it's an alternative to surgery. In many cases it's a complementary thing. So it's very common that a patient walks into the OPD, he has just headaches. We see a chronic subdural on CT, we embolize, we wait for a month, and the subdural collection goes away. I'll show you a few cases like that. But then there are also patients who will have focal deficit, they are paralyzed, they have difficulty in walking, talking, where you know you have to reduce the mass effected compression. So you block the artery so that it does not recur, and then you take these hematomas. Just a caveat, it is not, we are not saying it's a replacement for surgery. And definitely, as of today, it's not recommended for acute SDH. Though, as of 5 days back, there was a case series presented and published which is talking about in acute SDH also, but maybe the evidence will need some more time for that. So today what we are trying to do is embolize this so that we can stop this self-perpetuating cycle, and once the leakage stops, then the resorption of hematoma starts. So the whole concept was tested in 3 randomized controlled trials which came up and got published in NEJM, one after the other. And the message was very simple, that if you find a patient with chronic subdural, whether you are doing surgery or whether you are not doing surgery, you should embolize these arteries to prevent recurrences. And I can very honestly say that this is one of the easiest procedures we do in neurointervention. Just a notch above doing a diagnostic angiogram. Very simple, can be done anywhere, can be done in ESR. A reasonably trained interventionist should be able to do this, mostly under local anesthesia, mostly like a day care procedure or short admission of 1 or 2 days in the hospital. So we do a diagnostic angiogram, demonstrate these leaky arteries, and then just go ahead and block it. So this is the scan, and so what typically will happen is the collection will not disappear overnight. Do not expect that you have done an embolization and then next day we do a CT scan and everything will be okay. But that resorption will happen over a period of few weeks to months. But then there are a lot of patients like this which we are now following up. There are a lot of patients from all across the country who are coming to us, where they are mildly asymptomatic, mild headaches, severe headaches, but no focal deficit. You embolize these arteries, keep following up, do a repeat scan, and the patients go back to their normal life. And as I said, it's an adjunct to the surgery. It's not an alternative. So this patient had a big subdural collection, and this is a recurrence because it was drained at an outside center earlier. Patient came back, we embolized it, and then the recurrence stops. So practically in all the cases which we do now at Medanta of chronic subdural, we try to extend middle meningeal artery embolization to most of them. Okay, great. So till the time the projector turns on, I think it's right on cue. Any questions on that? Comments, suggestions? Sanjay, from neurologist perspective.
Sir, how minimum of symptoms?
Sorry?
How minimum symptomatic is the patient for chronic SDH?
So unless the patient is having a focal deficit, like if they are having headaches, only headaches, then the embolization alone is okay. But if there is a focal neurological deficit, then you need to reduce the mass effect. So then it's an adjunct. You do both.
Answering patients who have been previously operated?
Again, so if patient is previously operated, and so 2 subset of patients. One who just presents with headache and reaccumulation of collection, just the MMA embolization is okay. 2, there is a headache, reaccumulation, but again a new focal deficit, then you embolize and re-evacuate again. Like the guidelines from HASA is now very clear that you should embolize all patients of chronic subdural artery with a middle meningeal artery embolization. Now the question which, and there is no neurosurgeon here in the audience, the question which most of the surgeons do tend to ask is, why don't we just tie the middle meningeal artery when we are operating? So unfortunately it doesn't work that way. The material has to penetrate into distal capillary bed to stop. If you just tie up one side, the collaterals develop from the other side. Even when we are embolizing, even if it's a unilateral correction, we block both sides. Otherwise the rich anastomosis takes over and the idea fails. So long-term effects in the terms that, our personal experience is of 2 years, the world experience is of 3.5 years. But once you stop it, it never comes back. Except there are few cases in which you have not embolized bilaterally. If you have embolized only on one side, then the other side can take over and patient can still have a reaccumulation of those fluids. There is no implant here. So you are just blocking these arteries, so they stop oozing, and once they are blocked, they are gone. And most importantly, the headache goes off immediately. Like within first 24 hours, these patients are practically symptom free. So you keep on looking at a CT scan which will show these collections for 2-3 months, but the patients are asymptomatic, they feel headache free, and that's what we have also taken into chronic migraine. Since it works so well for middle meningeal artery, people have started using it for refractory migraines, and again it is working well with the same philosophy.
What is the cost?
Very cheap depending on which hospital setup you are doing. Practically at Medanta it costs something like 1 to 1.5 lakhs, and each hospital is the range of 75,000 to 2 lakhs worth of a range as well. As I said, there is not much of a material involved in this. So the glue which we inject costs hardly 10,000 rupees with everything. So very cheap. So another new era of headaches which we are treating now is the idiopathic intracranial hypertension. So this I am showing a story of the anesthetist. She was experienced chronic headaches to the extent she was hospitalized in her own hospital, then multiple hospitals and multiple super specialty hospitals, diagnosed with intracranial hypertension. Opening pressures were high. She was put on Diamox, responded, but then the typical pattern that the patient will have side effects of Diamox, he cannot continue for a longer period of time. So with the whole story, she, with the papilledema and everything, she comes to us. The MRI patterns are typical. The projector is not connected to UPS, and the mic is connected. We just wait for the pictures to come up.
You are audible without mic on.
So the idea in intracranial hypertension is we always used to think we have to do either optic nerve fenestration or BP shunt or lumboperitoneal shunt or Diamox or painkillers and management. But then there are these subset of patients who has again stenosis in the transverse sinus or sigmoid sinus. So the brain is not able to drain out normally. And I'm going to show you this picture once this comes up. So I'm sharing this because I have been doing intervention now close to more than 2 decades, and these are some of the new things which have come up in last few years, which we were not practicing, nobody was knowing that, and suddenly the world has changed to headache clinics, and the headache clinics are now manned by neurointervention teams because these sort of diseases, they are being treated in these unique stenting and management ways. आज चले गए चले गए So this is how the MRI picture sometimes shows that there is venous sinus stenosis. And how to get these pictures is we have to order contrast enhanced MR venogram. If you order only plain MR venogram, you will see a lot of artifacts. You will overdiagnose these cases and the treatment may not work. So the contrast enhanced MR venogram is the modality of choice. And even after that, we just don't go ahead and stent it. Like if you are just seeing some narrowing or blockage, that does not mean that the patient will improve. You have to select these patients carefully. So this is the way to do that. That you identify the pressure gradient. So we go through the vein, we cross the stenosis, and we measure the pressure gradient before and after the stenosis. So if the pressure gradient is more than 6, that means there is significant stenosis, and if you open up this stenosis, these patients will benefit. If the pressure gradient is less than 6, these patients won't benefit. So here we can see the gradient was 9, and that means that stenosis was significant, and this is the stent which we have put in to open up the sinus. And see this. This is the proof of concept. This is right immediately after you can see the pressure gradient has now dropped down to 1. So that means that blockage effect which the sinus was causing, due to which the brain was not able to drain, has been taken care of. And then these patients improve, the pain score goes away. Again, it's not immediate. It takes time for that pressure to subside. So typically a 2 weeks time period is what it takes for these patients to go back to their normal life. And occasional patients may actually feel more stretching due to stenting for a few days before it settles down. So this is again another patient, same sort of story, and very similar pictures, but even higher pressure gradient. So if you see here, the pressure gradient is of 18. So as I said, the normal is less than 6. So in this case, it's practically triple of what we should see. And once you stent it, it again drops down to near about 1. And these are the patients who will respond to these stenting procedures. So headache just does not always mean pharmacotherapy. So if these patients are having these unique symptoms, we can think of these ways, and there is a lot written about the pathogenesis, and this is how we select the good candidates for venous sinus stenting. It's not like every patient who walks in with IIH, we should offer venous stenting. We should first document that there is an opening pressure which is higher, CSF pressure. We should try the medical management with diamox and other therapies first. And if the patient is not responding, progressing, those are the subset of patients we will take up for the venous sinus stenting. So in the headache world, for migraine, for chronic subdurals, for IIH, that's where the role of interventionist is coming. And few of these patients, I don't know if you have seen that, they also present with pulsatile tinnitus because there is a stenosis right here at the transverse sigmoid sinus, and when the blood goes like, they hear that sound continuously, and the pulsatile tinnitus is also now being treated in the same fashion. So, but since the headache was the part of it, I didn't bring the pulsatile tinnitus cases. So that's also another part of it. again, so before we jump on to the next thing, any questions, suggestions?
If IA is presenting with vertigo, severe vertigo, then also this can happen.
So IA is presenting with vertigo, but how do we diagnose IIS? Like confirm
Like on MRI and fatigue.
so if it is there, I have not personally treated anyone with just vertigo, but I assume if the pathophysiology is same, they should benefit. But personally, no experience in treating only with vertigo. Okay. So this one is for the backbenchers. Can we identify all three? Backbenchers are supposed to be good in this, please. So this one is easy. So front benchers know Joe Biden by heart. So they have said Joe Biden. हाँ देखिए Daenerys. And the middle one for middle-aged people, Sharon Stone used to be the heartthrob in early 2000s. So any clue why all three are together in the same picture?
They all went to neurosurgeon.
Yeah, that is no, they all didn't meet the neurosurgeon. That's a difference. But they all come together in a neuro world. So all three of them had aneurysms. All three of them had ruptured aneurysms, which were treated, and the key message is it's treatable. Like, sometimes what we think, not as doctors but as community people think, if there is a brain hemorrhage, there is aneurysm, the patient can never go back to the life. So Joe Biden had twice undergone clipping. Daenerys has gone under clipping and coiling, and Sharon Stone was the leading figure to advocate coiling in United States in early 2000. So we know intracranial aneurysm can present with subarachnoid hemorrhage, and clipping and coiling remains the mainstay of treatment as early as possible. More and more patients now being treated by minimally invasive coiling routes, as it happens with every field of the medical science. Patient wants minimally invasive procedure. That typically just involves working like cardiologists. So we go through either groin or radial artery, we park a microcatheter inside and put these detachable coils and secure the aneurysm. But this is what we have been doing for the last 25-30 years now. So what's new about it? Everybody knows we can coil the aneurysm, so there is no big deal. So the news which happened again a decade ago was the flow diverter, that you don't even need to go inside the aneurysm to put coils. You can use these spatial mesh like stents, as we like to call them, and these flow diverters, what they do is they redirect the flow away from the aneurysm. So you are not even entering the aneurysm, and that makes these procedures very safe, because when we are going inside the aneurysm, there is always a chance that we can burst these aneurysms. Here you are deploying a stent-like device across the aneurysm neck, and what it does is it diverts the flow away from the aneurysm into the vein artery, and aneurysm slowly shrinks away and gets thrombosed, which is the desired result. So many untreatable aneurysms, which we will earlier send for surgical bypass, can now easily be treated by this. So look at this untreatable aneurysm where we cannot coil, we cannot do anything. We have placed 2 overlapping stents, and this is the follow-up of this patient after 6 months. If I just show you this picture of internal carotid artery, it looks perfectly normal. The aneurysm is completely healed and normal. So when we talk about aneurysms, we have numerous tools to do things. We can stent, we can clip, we can coil, and sometimes we have to use multiple modalities to do. So this is a patient who came from Bangladesh. She only has one artery working, rest everything was thrombosed. And we used spatial devices. These are very latest new devices called intrasaccular flow diverters, where you put these flow diverters inside the animal. So this is an example where we have used both. So this is the flow diverter for one aneurysm and this is the intrasaccular flow diverter for the second aneurysm. So idea which I want to say is that for all these patients, treatment is possible, feasible. Yes, it's very expensive in certain situations, but again, life is the priority, so it takes that. So I'll skip this embolization part and come to stroke. And again, stroke is one of the things I think which everybody of us should be talking about. And we all know about heart attacks, we all know about the protocols which one should do if somebody is even suspected to have a heart attack. But when we talk about stroke, we do not talk about it with the same passion. So I think we have to identify, we have to treat these patients with much more passion and urgency. The incidence of young stroke is on a high. We are seeing every day more patients coming to emergency rooms with strokes. We know ischemic stroke, blockage, risk factors are very similar to the cardiovascular risk factors, barring a couple of them. And we are seeing a lot of these now. So, going for a free massage at a barber, spa, and partying. Now you will say, why? What partying has to do with a stroke risk? Because when you are dancing, when you have taken a lot of alcohol, give your neck a sudden jerk, which leads to dissection of the carotid artery and vertebral artery either. That can cause to stroke. In last 3-4 years, I have attended to 6 doctors, just doctors, who has presented with dissection during party. So all this what we are doing, if it ends up with a dance, you are at risk of stroke. So these sudden jerky movements, spa massages, this is again a very high causing high incidence of stroke. Air quality indexes again leads to higher chances of stroke. So every November, December, January, we get to see more stroke, A due to winters, B due to air pollution. And we need to act fast because brain cells are dying. So I think we know about this, that we can thrombolize these patients to open up the artery, or we can use stents to do mechanical thrombectomy. Anybody knows the window period? What's the golden window period for stroke?
4.5 hours.
Somebody said 4.5 hours.
Yes.
So 4.5 hours for IV TPA. You can thrombolize these patients till 4.5 hours. That's rule of thumb. For mechanical thrombectomy? Perfect. 24 hours. Are we sending these patients to neurologists and interventionists till 24 hours?
No.
Maybe, maybe not. So I think windowing is very important because there are a lot of challenges in India why these patients do not reach hospitals in time. But I think those patients who do reach, we should be able to direct them to the right centers within our city or outside our city so that they can do that. So mechanical thrombectomy is very simple procedure to do. Again, it's not as challenging as doing coiling, but yes, of course, it needs a little bit of training. So typically in an animation world, if the middle cerebral artery is blocked by a clot like this, and if the patient comes within first 4.5 hours, if there is no contraindication, you do a CT scan and an MRI, and you go ahead and do thrombolysis. If thrombolysis doesn't work, your best next chance is to use these stent retrievers, which are non-detachable stents. So you can't detach them and deploy them. They will be just pulling out these clots. So everything is done under fluoroscopic guidance. So you cross these clots using microvires and microcapitals. And unlike cardiac stents, which are balloon mounted, so you need a balloon to expand, these are self-expanding. So I'm just going to run it fast. So you deploy the stent and eventually the stent will try to engage the clot. And then you pull these stents out. As I said, these are non-detachable ones. So the chances of them getting detached is 0. So you pull it out and sometimes in 1, 2 or 3 passes you can take out the clot depending on the size and site of the balloon. One of the common things which we talk about is number needed to treat. So what's the number needed to treat to make a difference? For an MI patient, that number needed to treat is 19. So if you treat 19 coronary primary angioplasties, you make a difference to 1. For stroke, that number is 2.4,
Only.
even higher than DFib. So these are very clear-cut guidelines based on 9 randomized controlled trials, that if the patient comes to you within first 24 hours, this is level 1A guide text, that you should be offering these patients chance to go back to their normal life. And just because we do mechanical thrombectomy does not mean that we should not give IV TPA. We should give TPA to all the eligible patients. If they do not improve or they are ineligible, then we do mechanical thrombectomy. So, very typical case, 42-year-old, the only thing atypical was that he came to the hospital very quickly, within first 1.5 hours. He has weakness of left side, NIHS was high, and we do CT angiography, CT perfusion to make sure that patient does not have bleed. Patient should not be having a large infarct to begin with, because then the chances of recovery is very low. So this is the patient as he came. You can see the facial palsy, not able to move left side at all. He is paralyzed on this side. Though following commands, because it's the right MCA which is occluded. So an angiogram, this was in beginning. MCA is occluded. Once we have taken out the clot using stent retriever, the artery opens up, and immediately on table the patient improves. The circulation is improved, and because he presented early, he had a very good outcome on the table itself, that he was able to move this. So I think I will end my thing with this presentation. It's a stroke pathway which we follow at Medanta, that as soon as the patient comes in, everybody gets activated, and let us give talk. We do all of them called simultaneous and not one after the other. We know that there is a stroke and everything that it gets notified at the same time. And we converge the CT scan room as the scan is being done. And there, since we all are there, we are able to take the decisions together faster for the better interpretation. The most crucial point in Indian healthcare system is whether we have to give thrombolysis, or to do mechanical thrombectomy, how do we do the financial clearance. So our hospital is very supportive, and we do not need financial clearance to start the procedure as long as the patient agrees that they will pay it up in the future, they will sign a disclosure, and we move on. So it's relatively easy and straightforward, and it helps the patients. In most of the cases, we are affected from this kind of investigations. We do blood sugar levels, we put in cannula in the arms, and we shift the patient in CT scan without wasting time. And CT, while CT is being done, we cycle and we prepare the patient to just discard only if it's not already put from baseline to putting catheter in. We just secure a basic IV analysis, usually there for the CT scan, quickly break the patient, and we work in parallel with the team members. You'll see is trying to do a puncture, the other person is preparing the heart test, and quickly we can go access to take the clot out. After taking the clot out, we can also do a CT scan to make sure that there is no leak visible. So we talk about this, but eventually what makes the difference here is the activation of the stroke code, that everybody gets activated. It's not like first somebody will see, then they will call somebody, and then eventually things happen. And once you start making differences to patients' life, the hospital starts supporting you as well. So I think we have been blessed that we have been doing this for last 14-15 years now at Medanta, and we are very proud of the way we run the stroke program, and we want that each hospital in each city should be equipped to do that. So because there is so much of scope to treat, no one hospital or one center can do it alone. So I think everybody should pitch in there. Thank you so much. Thanks for your time.